all the work behind the scenes before the patient comes back. So we tell the patient, I'm going to spend my time programming your final bite, setting your mechanics, the depth attachments, and when you come back, then we're going to deliver, we're going to go through the treatment. I'll see you every 8 weeks, 8 to 10 weeks, whatever your particular practice is, and then finally we'll have retainers. We may go through this process twice to get a great finished result. So you'll know by then how severe, how complex that malocclusion is. So if we take a patient such as Lily, very important again that we connect, and we can do that very accurately and intimately as we're scanning with the patient. It takes just a few minutes. All the diagnosis and treatment planning is the same as what we would do with FIX. So we're going to look and see if it's surgical candidate. We work from the outside in. She has a beautiful profile, no need to change that. So what's that telling me? It's telling me that already I have set up my ClinCheck. Already I know that my anterior limit, usually I start on the lower arch, is going to be the same. Unless I want to bring the uppers in a bit, then I'm going to tuck in a little bit. But I don't really want to change her profile, in my opinion, not a chief concern. So my anterior limit, I don't want to procline her lower incisors, I don't want to necessarily retrocline on the ClinCheck. They're going to be pretty close to where they started. Of course, all the deep bite we look at, the facial midlines, the crowding and spacing that's present, and whether she needs any AP change, the buccal interdigitation. The set will show us again the profile, whether we want to change that. She is a mild class 2, but nothing that really requires surgery, but those lower incisors will probably stay a little bit proclined to compensate for that lower jaw position. And on the OPG, of course, we're looking for pathology, impacted third molars. If I was going to distalize and she's old enough, maybe I would send her to have them out beforehand, but I don't need to distalize a lot in Lily, if at all, so they can stay until they need to come out for another reason. No big tipped roots there, so we can make our treatment plan. Minor front tooth treatment to straighten the front teeth and normalise the overbite and overjet, because her buccal occlusion is pretty good. So someone like Lily will probably be an essentials patient. So if we look at the ClinCheck here, yes, it was 26 stages, but you can easily treat her in 20. That was because we have a moderate package, and that's what I used. So I used every stage, but the lower I think was very few aligners, much less than the 26. And on the upper, I usually don't go to the last stage anyway. If I'm going to have additional aligner, it's probably 24 or 25. But very efficiently, we can see the deep bite is corrected with those deep bite attachments here. We'll look at that a little bit later. She doesn't need to wear elastics, but they're there just in case. But again, if it's essentials, they're not going to be there. So we get to this point and we look at her outcome, and I think, gee, that's actually pretty nice. I could really stop there. Maybe she's got a slight opening here or a slight spacing. We're going to look very closely, but either way, we're going to scan. Because we can use the scan to either go straight into retention, or we can use it to go into additional aligner. So this is the decision that we usually make when the patient's in the chair. Are they happy with their teeth? The chief concern is satisfied. Are our treatment goals satisfied? Anything that we would like to accomplish? If we're going to move teeth, if we're going to go through the process of programming and manufacturing and delivering, is it even going to help the patient? Sometimes, no, it's not, so there's no point. And if we do that, is the patient going to actually wear the additional aligners? Because if they're happy and they've already been in treatment for 4 months, 6 months, maybe they're not going to wear more aligners because they're already happy and their compliance goes down. So I always say, if I'm planning on it, I'm going to spend my time programming. Are you going to actually wear them? Not just at night or half time, 20 to 22 hours. because they're very fine movements now, very important. So the way we decide, people say, how do you know when an Invisalign case is finished? The same as how we know when a fixed appliance case is finished. The chief concern of the patient, the way we have our objectives, and would further movement be of any benefit? It's the same. We don't just keep going round and round and round and round. Okay. And the last point there was, is additional aligner order possible? Because as we know for some products it's not. We know for essentials there is one, I think, additional aligner product that's included in the product, and one additional aligner series that's included, which is great. So that's our finishing. So we want to get as close as we can in that first series, in that first 20, so that we might only have 5, 8, 10 aligners in the finishing, additional aligner to satisfy our goals. So you can see very, very slow, minor movement, really just tiny amounts of buccal root talk, just tightening that occlusion. Sometimes in a young patient it might be bringing up, allowing the 12-year molars now to erupt a bit more if they've had some growth over that time. So there she is, there's Lily. And of course we can go to my iTero and get all these wonderful images using the same login as you do when you log into your IDS site or your scanner. It's all integrated. So on the one hand, the additional aligners allow us to get closer to our goal. It may, if bite shift, it may help us capture centric relation. It may include teeth that are erupting, like I said, the 12-year molars. We may now, or in Invisalign first patient, we need now to capture those teeth, or to finish very fine movements. On the other hand, it takes additional time and effort. Now the clinical time should be very small. It's actually the shortest appointment, right? Because we just scan, stay in that aligner, whatever number it is, wear that. Usually you only have to wear it at night because it's just retaining, and it may be for 3-4 weeks until the aligners come back in. It does increase treatment time, so we have to make sure that it's going to be of benefit to the patient. We need to manage the programming period. So what's the patient doing while the aligners are being programmed and manufactured? For me, usually just wearing them at night time, and always having that spare one, either one before or one after, so that if they lose the one they're wearing, they can move one either side of the scan, but don't keep going if they had more aligners to keep going with. We need to scan, that's 3 or 4 minutes. Especially with the luminous scanner, it's very, very quick. But even with the beautiful iTeros, another one which I have right behind me here, you can't see it. There we go, you can see there, one in the clinic. Even then it's 6 minutes, 7 minutes if you've got someone who's great at scanning. Additional programming we need to do, and possibly new attachments. So if we need some new biomechanics, if we need to extrude a tooth a bit more or rotate a tooth, we're going to consider, do we keep the same attachment or do we change it? We know that patient satisfaction this is just sort of my idea about how the patients react to Invisalign treatment. Usually they're very excited at delivery, they're a bit nervous because we've warned them about responsibility and attachments, and it's got to be a bit sore. And the first week is hard, right? Because they have to take them in and out, they don't know how to do it properly yet and easily. Their teeth are quite sore compared to the rest. So usually about 3, 4, 5 days until they get into that habit and the teeth stop hurting. Then in the first series, as the teeth straighten, they get more and more excited. And then as the teeth straighten, usually the front teeth are chief concern, and we get, the smaller movements are happening, the excitement wears off, they're already happy. And then we come to the point where we're finished, additional aligner 1. Do we need it or not? And usually the patient's happy. It's something that maybe we need to do. And the satisfaction maybe goes down, and definitely the more aligners you throw at them, their satisfaction will go down because they're usually already pleased in that first series if we've set up a good final position in that first series. So it's a double-edged sword, additional aligners. There are lots of positives about it. We can finish very well, get a great outcome, the same or better than fixed appliances, but it does take extra time and it's something that has to be used properly. Otherwise, the patient's satisfaction goes down. And guess what? When the satisfaction goes down, guess what else goes down? Their compliance. And without having this in the patient's mouth, then the benefit of that series is being lost. So can we finish in one additional aligner series? If to do that, all of these three things need to be equal or very, very close. Our treatment goal, our ClinCheck final position that reflects the patient's chief concern, and the clinical result, right, which is going to be the degree of expression of movement, how good the aligner is at creating those rotations or satisfying, extrusions, all of those movements, closing spaces, and the patient variables. All those things have to be very, very close to finish in one aligner series. That's a very difficult thing. When we look again at the system, and the biggest variable is going to be the patient. So it's sort of like golf, right? It's possible, but it's like a hole in one. It doesn't happen all the time. You can be the best golfer, Tiger Woods, expert golfer, best equipment, Invisalign, on the best course, the most compliant patient. But there are other variables here, the wind, the grass, what you had for dinner the night before, all those variables that we can't necessarily control to get that hole in one. We always aim for it. We always aim to finish in one series of aligners, but the patients know there's probably going to be a finishing series. And I tell them on delivery, there's 20 aligners here. At 20, the computer says you should be finished, but it's going to depend how well you wear them. If you don't wear them as well, we may have a few extra, so that the patient knows, they want to be finished at number 20, they don't want to have extra aligners. How many times did Tiger Woods get a hole in one in his whole life? 20 times. Only 20, and he's played a lot of golf, and he's an expert. So here we have Aiden, a 15-year-old male patient, skeletal class 1, mesotelico, very procline incisors, but he's happy with his profile. He doesn't feel like it's too full, neither do his parents. Again, looking for tipped roots, maybe that we want to control. We make sure an attachment is triggered there, optimize attachment, and we're going to set up the best ClinCheck that we can. And these days, it's really main attention to ClinCheck is on the final stage, right? What does the final stage look like? Because these days the defaults for attachments and the defaults for IPR, the defaults for staging are getting much better, but the final position is something that's what we're responsible for as orthodontists. We know the patient, we know the patient's face and the lips, so we need to get this looking good in Aiden's mouth. So let's see where he finishes. There's a little bit of IPR on the lower. We're opening his bite a little bit more, so a bit more overcorrection on the overbite, as he started a little bit deep there, and that's the final position. So what do you notice about the final position here? The upper smile's probably going to be okay. It's a very straight smile line. Upper and lower midline, not coincident. Maybe it doesn't matter, maybe he's got a chin asymmetry, but if it happens here, don't be surprised if it happens in the mouth. And that's exactly what happens. Upper and lower midlines, the buccal segments look beautiful. There could be a bolus discrepancy or an asymmetry, but what you see on ClinCheck is very often what you'll get clinically or slightly worse. So we want to make that final position as accurate as we can. Now we did finish here. There's no point getting them matching midlines unless it's, you know, very close. The buccal segment is more important to me, definitely the upper midline, but we don't walk around looking at our teeth like this. It's more the interdigitation and the upper for me. So this is where we stopped with Aiden. He was a hole-in-one, and we did get very, very close to the clean check. You can see intrusion is something that lags a bit. We very slightly overcorrected that, but he finished in one series of aligners. So watch out, yeah, that's, you know, whatever you prepare on clean check is pretty much what you will receive clinically. So nice, you know, parallel roots. We improved the canine a little bit, and profile-wise, he stayed very much the same. Ninth occlusion, he has a nice interdigitation, good canine guidance there, and can't see the guidance because it's static, but good canine stops and good occlusal compacts. And that's at that Vivera scan, so that's even going to settle even more. And of course, we just order the Vivera, the digital retainer. So in reality, we know most cases the treatment goal is a little bit different from, because it's theoretical in our mind, and we have to be good at transferring that to ClinCheck. And then that can be very different from the clinical result, because the clinical result has a lot of variables that we can't control, such as, like I said, the biggest variable are the patient variables. We're going to try and control those as much as we can, but we can't be with our patients 24 hours a day. So what can we do to control the biggest influence on whether we might need additional aligner series? So if we look at, you know, first of all, it's what the patient presents with, right? How complex, what are we treating here? If it's going to be a mild malocclusion +1, mild crowding or mild spacing, then we can usually satisfy either, if not a hole-in-one, we're going to get very, very close. 80–90% of the treatment of the movements we should express in that first series. So we would, if it was a more complex case, then we would aim to get rid of mandibular shift if there was a crossbite or programmed root movement, because that's something that takes a lot of aligners to do. But if it's a mild case, we want to get as close as possible, try and get that hole-in-one, so that then we can, if it's again mild +1 crowding or spacing case, no need for AP movement or elastics, then it could be an essentials case if it's mild. The more complex we go, we might need a short finishing, fine-tuning, maybe there's a bit of torque, maybe tightening buccal occlusion, maybe, as I said, in a younger patient, erupting a little bit the 12-year-old molars that have been held down through that initial, or maybe they've just erupted through that initial treatment. Why do we have maybe 2 additional aligner series or more? It's going to be complex, right? It's going to be a complex case, maybe canines, maybe an extraction case that we didn't manage very well. We know that we don't want this because there is a big risk of patient burnout. And as I said, usually, even in a complex case, the patient's pretty happy early on. So we want to avoid more than one additional aligner series if we can. So my strategy for minor cases, get very, very close. So if we're playing golf, we want to get on the green, either in the hole or very as close as possible to the hole. So there's just like the detailing to do on that final series. The other thing we need to think about when we talk about finishing, because remember, additional aligner shouldn't be an excuse for something that didn't happen. It's a finishing process. What number do we want to finish in? Do we want to finish in aligner number 10 or 45? Remember, the more steps we have, the more likely we are to have error, the less the aligner fits perfectly. So we get greater of the expression of movement when we have fewer aligners, a very short finishing series, than even finishing in a hole-in-one, even at aligner 20. case evaluation. This is a really interesting article that I just found recently, and it actually looks at this whole question about, you know, the patient's reaction and the benefit of doing additional liner series. And what they found was the more additional liners we have, exactly what we've been talking about, the patient satisfaction goes down, and the amount of improvement that you get for each one actually goes down as well. So we get the most improvement in the first series, and then if we need that small final finishing series in a low number of aligners. So engage, connect with the patients. We do our scan, we plan effectively, we'll look at some clean check planning, how we can make that you know, closer to getting on the green, closer to finishing very, very closely in that first series. We're going to monitor our patients very well. When they come in, we're going to check their compliance, and of course we know that just before they even sit in the chair. Hi, how are you? You're wearing your aligners? Fantastic, you should be. I can't hear you, you know, lisping. I can't see the aligners on your teeth, even though you're wearing them. All of that already I know you're compliant. If you can't see them very obviously, if the patient knows how to speak with them without lisping, we're pretty sure they're already very compliant. Look at the patient lies down, we have a look at them inside the mouth, they're conforming, they're fitting well around all the teeth. If we see gaps or bubbles, we remember where they are, so when the aligner comes out, we check those areas. Now the aligner comes out, the patient might take it out, we give them some hand sanitizer, they like to take out their own aligner usually, and then we check the condition and the number of the aligner. Oh, yeah, okay, number 16 today, that's great, that's where you should be wearing, and it's quite clean. When did you put it in? What's your change night? On a Thursday night, that's been 2 days, great, okay, so it should be nice and clean anyway. Then we can check the contacts. Was there any IPR programmed from our treatment sheet or on the ClinCheck screen? Then the patient bites down and we look at the bite. Do we need to run elastics, class 2 or class 3, so our ankle classification. And then the changeover. So this is the 6 C's, right? The changeover. That's great. You're wearing them well. Everything looks good. Maybe a slight gap happening here on the upper right. You know, this tooth here. Show them with a mirror. Make sure you put it up properly. Use the squeezy on that tooth. Otherwise, keep doing what you're doing. Make sure the hours are up. And here are your next aligners. We'll see you in 8 weeks or 10 weeks or whatever it is. So monitoring and always reinforcing these things every time we see the patient, really important. And then, of course, retention. Otherwise, it's all for a waste. So when people talk about Invisalign, you know, it's not all about the aligner and then the teeth and then the patient. That's the wrong order, right? It doesn't start with the aligner and the tooth and the patient. It actually starts with the patient. And that's where we want to connect. So whether you connect through your scanner and the software there, or you know, visualizing the patient's teeth in their mouth. If you can't do that in your practice, then figure out another way of giving this information and really making this connection and this bond straight away, so that the patient will comply with you. Then it's about tooth control and our treatment plan, where we want the teeth, and then Invisalign is the mechanics, right? Doesn't start there. That's the last thing we consider. Patient, what they present with, their chief concern, how old are they, 5 or 95, any special things in their life, do they travel a lot, can they actually come to appointments, what kind of jobs they have, and then looking at our treatment plan, where we want the teeth, and then finally, what kind of mechanics do we need to produce that treatment plan. So remember at the beginning, I said there were 3 essential ingredients, right? The aligner and the patient and us, the clinician. So if we look at those 3 areas and question why additional aligners, what can we do in those 3 categories to minimize the need for additional aligner series? So we can program the aligner very well. We can get very good at ClinCheck. We're talking about the patient here. lack of compliance will definitely affect whether we need additional aligners. Inappropriate aligner use, how they're putting it in, whether they use a squeezy, whether they put them in the morning or the night, how often they change over. And of course, things that we can control much less, such as the complexity of the malocclusion and things like their age or their bone height. But these two things we can try and control and manage: compliance and the aligner use. In terms of compliance, a lot of us are afraid when we have a young patient like this come in, and you know, in the early days, Invisalign was just really targeted at adults. For me, teenagers are the best, easiest patients to manage. The elderly patients or adult patients who are very busy in their lives, and have, you know, thick bone or missing teeth or crowns and bridges, or the very young patients like this patient here, maybe there are additional challenges. So, you know, there's a reason we treat mainly fixed appliances in teens, because we have a bit of growth, they have beautiful dentitions, their bone's nice and much more responsive to orthodontic forces. So when we have a young patient like Charlotte, we may be thinking, oh gosh, she's not going to wear her aligners. But, you know, giving them a chance and present the two systems and see, because for a patient like this who gets teased and she's very concerned, she's, you know, you can see that chin mentalis strain here, that lip incompetence that we have. Can we help with, you know, a phase 1 treatment to just tuck in those upper incisors a little bit and organise her phase 2, so make that a little bit more satisfactory, and maybe, if we can, avoid extractions, or at least improve her appearance in that phase 1. So I'm talking about here managing, I guess, compliance with very, very young patients. Treatment planning is the same. We treatment plan her for a phase 1, the major aims of phase 1, during mixed dentition stage, to retract the protrusive upper front teeth, create some space during expansion, and coordinate those arches. And, you know, when these patients are young, they can understand Invisalign, but we also need to keep monitoring them through that regular touch point. And just because the patients are young, again, the literature tells us you can't ever just predict how compliant a patient is going to be. Not age, not their gender, whether they're male or female, not whether they're wealthy or not as wealthy, not whether they're well educated. None of these things produce compliance. So for every patient, we prepare them as if they're not going to be compliant. You know, we've had plenty of removable appliances in orthodontic history, right? We've had face bows, these, you know, Hawley retainers. We have removable expanders. We have removable functional appliances. And we think about compliance, but they're things that we can prescribe to our patients, and we always have through the history of orthodontics. But then when it comes to something like this, which is easier, much easier to use than any of these things, clear, and the patients can see the change, we're worried about this as compliance? No. You know, I think it was a much bigger problem than what we really see in clinical practice. We keep the instructions very simple, so we make our own very basic instructions so the patient's not overloaded. They can focus on what they need to do. Only take them out for drinking and eating. Water is okay. And soft drinks, take them out for soft drinks. No sports or you know, soft drinks or sports drinks with the aligners in. Young patients tend to have some of those things, so we put that in a separate instruction. Keep them in the case when they're out of your mouth. Clean them with toothbrush, toothpaste. Change them once a week, whatever night it's going to be. After dinner, use the little squeezy. Usually it's 2 to 3 minutes, not 5 minutes. Bite down, hold, release. If you lose one, go to the next one. If it doesn't fit, go back one, and that's it. Don't throw away your old ones just in case. Very simple instructions. So, we treat these patients the same way. We don't predict for them that they're not going to be able to cope with Invisalign, because again, you think teenagers' teeth move very easily with aligners, so do these very, very young patients. And it's all about, communication from the beginning. The more effort in preparation in the beginning with Invisalign, the much more efficient it is at the end. There's very little to do apart from just having nice conversations, always reinforcing. Communication, we show them the pictures, they can see the scans at their progress visits if they want to, they can look at their simulations. We can use compliance indicator on the aligner if we want to customize it, like a placebo, so they know that we're looking at the amount that they're wearing their aligner. We're seeing the patient every so often, either virtually or face-to-face. I like face-to-face. We can make it fun for these young patients. We can use stickers, because sometimes when I would rather work with Invisalign if it's a distalization or dolichofacial patient, and the patient might say, or on braces, I'm like, why? And they might say the colours. We've got colours on aligners too. But when we take a patient like this who has, very obviously complex, so we don't even have to talk anymore, and this is not going to be a hole-in-one, right? This is going to be maybe even 2 or 3 additional aligner series before we get our final result, because she's got 2 impacted canines. They're not even there, just like Charlotte, the teeth are erupting, so we know they're not going to be a hole-in-one. But our phase 1 objective of taking back that overjet, very simple objectives, can be a hole-in-one, and then we wait for the teeth to erupt. So we educate the patients as they're sitting down. We can look at positives and negatives, well locked in buccal segments. Great, I don't really want to move those if I don't have to. Negative is a crossbite for additional aligner. Why? Because it can make a mandibular shift, right? We don't know if that mandibular mandibles being shifted, COCR, because of a crossbite interference. And they might be here because she's got definitely midline deviation. Space opening is required. We need to open space. That's good. Aligners love to open space mechanically. We know it's going to be a lengthy treatment time. She's not going to be a hole-in-one. She's going to be at least 2 or 3 additional aligner series because it's canines. And she's a frequent traveller, so we need to make it very clear that she's coming to the clinic. So when we're preparing our ClinCheck, what are my goals here? My goal is to maybe not get a hole-in-one here, because I know, it might be a par 4, so I can't straight away aim for a hole-in-one. But what am I going to aim for? I'm going to set up my play very well. I'm going to start creating space. I'm going to start bringing down, surgically my mechanics. How are we going to bring down the canine? I'm going to build that in with a hook and an attachment for the lower. So we're going to prepare. We're not going to go for a hole-in-one here. She may have a mandibular shift as we start crossing that bite, correcting that cross bite. So here are my mechanics to extrude the palatal canine, a hook on the lower aligner, and a retention attachment there. If I do need to use another tooth to actually bring the canine towards the arch form, I could put a button here, so I have a button cut out. So I'm thinking about the mechanics for that canine. So button cut out, extrusion, because we need to extrude it before we can bring it over. For the right side, we have a lot of vertical overlap.